Okay, story time. So I had this patient super sick, but they never had anything wrong with their lungs. And then all of a sudden, the patient became hypoxic on 100% oxygen, and we got a chest x-ray and it looked terrible. I know what you're thinking because I was thinking it too. This patient has ARDS. I just thought it was really important to go over because when it happens, it is so important to know what you're doing so that you can stay ahead of it. So what is it? It's acute respiratory distress syndrome, acute non-cardiogenic pulmonary edema, and it's caused by diffuse alveolar damage. Commonly, this is triggered by sepsis, pneumonia, aspiration, trauma, or mass transfusion. The worst case scenario is that these patients may need ECMO. A lot of hospitals aren't ECMO capable, so having those arrangements ahead of time is so important. Pathophys in 10 seconds. So think inflammatory cytokines leading to leaky alveolar capillary barriers, leading to protein-rich edema and surfactant dysfunction. Then alveolar collapse and severe shunt physiology and hypoxemia. Essentially, these little alveoli are filling with fluid. How do we diagnose this? So the Berlin criteria guides us. Acute onset within 1 week of insult with bilateral opacities on the chest X-ray or CT, and then their PaO2 to FiO2 ratio is less than or equal to 300 on a PEEP greater than or equal to 5. And then it cannot be explained by heart failure. And then the severity is also stratified here based on their PaO2 to FiO2 ratio. Mild would be less than 300, moderate would be less than 200, and severe would be less than 100. So how do we treat? The cornerstone is with lung protective ventilation. So your tidal volume is something that you can play around with a lot. A lot of times you can go from 6 milliliters per kilogram of their predicted body weight, even down to as little as 2 milliliters per kilogram. You'll want to really push up your PEEP to keep the alveoli open. And basically you want to push up your PEEP and decrease your tidal volume as much as you can, as long as your plateau pressure is less than or equal to 30 centimeters of water. You can accept some hypercapnia. If the hypoxemia is still bad, you can consider prone positioning, especially if the ratio is less than 150. And early neuromuscular blockade can help in some cases. Think about their fluid status too. You'll want to be conservative once they're resuscitated and even consider diuresis. And then you can think about inhaled nitrous oxide or even ECMO. This other one is really cool. There's something called the DEXA-ARDS trial, and it talks all about steroids. They use dexamethasone 20 milligrams IV daily for 5 days, and then 10 milligrams IV for 5 days in moderate to severe ARDS patients. There were more ventilator-free days and lower mortality compared to standard care.